So thoracic disc herniations, I mean, first of all, before I forget, the fellows and everyone here get all these guys' numbers, right? Everyone loves to talk about endoscopic spine, right? Everyone, you can see and you can feel the energy in the room. I feel like you should leverage that for opportunities now and any opportunities in the future. So thoracic disc herniations, we'll keep the objectives pretty simple, and then we're going to jump into a live demonstration in the lab, so I'll try to set us up for that. We'll talk about the technical pearls and some of the pitfalls. Clearly, everyone leverages a scope in their own way, and I feel like everyone does any of these bullet points here, right? Everyone's doing discs and synovial cysts and infections, and we saw the whole gamut of how you can apply the endoscope to the spine. And obviously, for this, we'll talk about thoracic disc herniations, and we'll talk about the basics. I'll just talk about how I do it. There's a number of variations. But let's see if I could use, there we go, cool. And then some of the future applications. So quick hit facts, again, there's a benefit of going on the second day and later in the second day. Everyone already gave you all the data, so we can skip through a lot of it. Less than 1% of all disc herniations, thoracic spine, soft or calcified. Most are actually calcified. They can come in all shapes and sizes. They can be in all these different places, so you have to tailor your treatment to what your pathology is. You operate for, and we all operate for, progressive symptoms and pain that's failed conservative management. So the goal of any surgery is to decompress the structures, preserve the function, and give the best chance for functional recovery. And we have to do that in thoracic spine, all while avoiding spinal cord manipulation. Talked about all these approaches, various ways to get to the same spot, pros and cons for each. There's still no standardized, approach for this, but again, you can make your case for any of these actually. The considerations, whether it's open, MIS, endoscopic, they're all going to be the same. And again, we talked about the complication rates and the considerations you need to make when you're dealing with thoracic discs. It's anywhere from visualization to the actual cord to canal diameter in the thoracic spine, right? We all have this general gestalt that the thoracic spine is the most sensitive area of the spinal cord. And that's probably because of this, and probably because of the watershed zones and all this other stuff. So I think it's important to keep in mind any time you're around the spinal cord, specifically in the thoracic spine, even compared to the cervical. There's large bony resections and collateral damage. Depending on what approach you take, you want to minimize all of that. When you talk about spinal fluid leaks, it's a much more serious spinal fluid leak if it's into the negative pressures of the thoracic cavity. So that's also something to keep in mind, and all the way up to your institutional resources. Who do you have available? What technology do you have to make any of these approaches as safe as possible? So the considerations, again, same for endoscopic thoracic disc resections. This is sort of a nice overview of what it means to do a thoracic disc with an endoscope. The indications are more or less going to be the same, but we'll go on the next slide on how that specific more considerations that you can have when you're using the scope for that. Planning is the most important in any surgery we do. Again, especially in the thoracic spine. If you get your trajectory wrong, if you identify your pathology incorrectly, if you don't localize it to a correct side, if you don't evaluate it enough preoperatively, if you don't have the right goal, you're not going to do the right surgery. So we'll go into some details there. The pros of endoscopic surgery, we don't need to sort of go over, but that's sort of listed there. The cons of this is, obviously, it's a steep learning curve. A lot of people have asked me already, and people are going to keep asking me. One of the most common questions is, how many cases do I need to do before I do a thoracic, right? And they never like my answer because it depends. You only know how good you are with the scope. You only know how good you are with learning things. It's super specific to not only the patient, the pathology, but it's to the surgeon too, right? I can give you a number. I could say 10. I can say 50, but it's going to be different. But if you really want a number, globally the consensus, I'm sure we all heard these numbers, like 50 to 60 lumbar cases. I would argue do maybe 10 or 20 cervical and then do some thoracic if you want some numbers. So from an indication standpoint, there's a few things that change, right? So you have these large calcified thoracic discs, and some would say they're giant if they're more than 40% of the canal. So if you look at this, take a deep breath, you take a step back, and you say, what am I really trying to accomplish? And obviously, the most important thing is what the patient's complaining of, right? Are they myelopathic? Are they complaining about radiculopathy, but on your objective exam it's myelopathy? Or do they only have radiculopathy? What are you trying to solve? Because it's going to really change what you're going to do for this patient. If it's myelopathy in an older patient, you're probably going to want to get that central stuff. If it's just radiculopathy, maybe you can try a scope and take care of that exiting nerve root and help their symptoms, and then keep that chronic disc that's been there for probably their whole life and just follow them closely. So it all really depends on what you're trying to accomplish. But the good thing is, if this was a foraminal disc that's ventral to a facet, traditionally, even if you did a tube, you'd have to take that joint off. And some would argue maybe fuse, maybe not, but you're helped by the rib cage there, so maybe you don't have to fuse. But the less bone you take off, the less consideration you have for instrumentation or fusion. So if you sneak under or ventral to the facet with a scope, then you can take that small disc that's causing that radiculopathy versus doing a large surgery for a small problem. And you probably have a lot of people I know in my community that's been coming to me walking around with thoracic radiculopathy, but never got the surgery because the surgery was too dangerous to solve that small problem, which was radiculopathy. You saw the OR setup. I'm the same. Screens are opposite from you. You're on the side of the pathology. Everyone else is on the side with you. You plan again, then you mark your trajectory. The next slide, we'll talk about how to do that trajectory. But it's very similar, the same principles. That's why you do those lumbar cases and cervical cases before. It's the same principles. You get your needle towards that target, plus or minus reaming. I know some people ream, some people don't. I didn't ream, but then I started reaming, and then I went back to just drilling. I think it's just faster. You'd find that when you're in the thoracic spine, there's actually less bone to go through, so you're not saving a lot of time with reaming, and I feel like, I don't know, for me it will add a little bit more complexity to the surgery. And then once I stick that scope down after I ream, I always find there's just too much junk to clean up. So I get that nice, that painting maneuver with the drill, and you don't have a lot of junk to clean up after reaming. That's just my workflow. So then you put the scope in, and you identify the anatomy. This is going to be the most important, right? Finding home, finding bone, and then using your x-ray as a confirmatory test. You never want to learn off your x-ray after you get it, right? You put your instrument on a bone, you think about what bone that is, and then you take a picture, and if the picture's right, then you're good. If the picture's wrong, then you got a little bit more thinking. You'd never want to put something there, take a picture, and then figure out what that is, if that makes sense. So then you enter the epidural space just like any other case, and you remove the pathology. I think Meng said this earlier, you want to miss shallow, right? And that's most important here, right? You never want to be any of these red arrows. If I'm letting a resident do this, I don't want to see that. You don't let it get that far. You always want to miss shallow. So if you're anywhere here, that's fine, right? You're in the muscle, you're hitting bone, you're in tissue, you're in ligaments superficially. You're okay. You can fix that. The other things would lead to obviously some bad problems potentially. So the other frequently asked question is, what's your trajectory? What's the, how far off midline do you go? And the answer to that is it depends, right? It's, again, patient-specific, pathology-specific, right? It's not going to be 8 centimeters for a BMI 60 with a central disc. That's just not going to be the case, right? And it could be, but you're going to have to do a lot of drilling if you choose that route. Whether the disc is rostral or caudal is going to change your trajectory as well, and what you're going to see, and more importantly, what you're going to reach. And we've been saying this too in all the labs. These are angled scopes, right? So you can see a lot of stuff, you just can't touch a lot of stuff. So you're gonna have to be prepared to sort of work through that frustration. And you can touch a lot more things if your trajectory is a little bit more super specific. So other miscellaneous things that we have to worry about is scar tissue stimulators, right? You're coming in a completely new approach. So these stimulator leads are going right sort of where you are, especially when you're in the lower thoracic. You want to make sure that you're not, taking out some of those very crucial leads that some of these patients still need. Rib morphology. All these pictures here are supine imaging, the CTs and the MRIs. So what you're seeing is how they're laying down, how the ribs are laid down when they're in a supine position. But when you're operating on them, what I'm seeing is that the ribs are sort of falling away, and they have a different morphology and orientation than where you're doing your measurements on the imaging. So that's something to take in consideration. So from this MRI, just looking at it, it doesn't look like you have a lot of space to deal with, but you find out in the operating room you have a lot more space dorsal to all the bony elements, dorsal to the intrathoracic space. So you get pleasantly surprised from that aspect. But your angle, and you'll see in the lab that we're limited to the rib morphology as far as the trajectory you can take. So these are some of the x-rays you like to see. Whoops. If you know that there's a spinal needle there, if I can point. Anyway, so you see the spinal needle. That's the only thing that's static in your whole surgery, right? This isn't a tubular surgery where something's attached to the table. That's the only thing that's not going into another place. And especially when the thoracic space or the thoracic spine, you can get easily disoriented when you keep taking x-rays and if you're not using navigation like Lynn does, right? So you have to make sure that you're looking at the same level and operating on the same level. Whether there's, a calcified disc there that you can see on the x-ray, something's got to tell you. And then, people like, getting IR to put beads there, that's also fine. But I like to follow the thing that I put in there, and that's that needle that stays there contralateral to my approach angle so it doesn't get in the way, and it's always on that inferior contralateral pedicle. Because millimeters of trajectory from the skin level can put you at a completely different level. So the first picture is just a 3.5 millimeter drill on the SAP. We've seen these pictures before. And then that second picture there is the cannula, sort of where you want it to dock. Because remember, that bevel is opening, and your camera is also pointing that way, so you're able to see more medial from that area. Then you pass ball tips, make sure you're above and below the disc space. So these are some pictures. I always like to identify the joint. IAP, joint space, SAP, right? So this is a left-sided approach. You see cranial on the left and caudal on the right. And that's exactly where that SAP arrow, that's where I want my drill. So I'm pointing that drill onto that SAP, because once I remove that SAP, I'm in the epidural space, or if there's a paracentral disc, I'm gonna see disc. So that's how that looks. So that's me drilling out the SAP, and then now you're gonna see some ligamentum flavum there right after that SAP is gone, and then you remove that ligamentum flavum, and then you start seeing cord and epidural fat. So this next video here is, you can see a lot of stuff there, right? You see the soap bubble looking fat. You see some various layers of, transparent stuff. You see a disc there. That's the space at around 5 to 6 o'clock of the space of the disc. And you see this tissue that I'm playing with. That's not the dura. It looks like dura, but it's not. It always sort of, is tricking you before you get to the dura. I call that the pseudo-dura of Nelson. I name it after my chief resident because he always gets in the way. So then then you remove that, right? And it always used to slow me down because you think it's dura and you're really slow and you don't want to hurt anything because you don't get any redos, right? But then what I always say now is like trust the fat, right? If you see layers here and then there's fat going through that layer, you can remove that layer. It's not going to be your intradural space, right? So you remove that, and then all of a sudden you see a nice dura. So here what we're looking at is, let's see, can you see if you see the mouse, okay, good. So that's the curved bipolar going contralaterally. And what you can faintly see there through that little hole is the contralateral spinal cord, okay? And what you're seeing at 10:30, 11 to 12 o'clock is that last remaining portion of that compressive disc. And this is all within the disc, okay? So if that makes sense, the last thing you need to do is take that pituitary upbiting or curved pituitary and remove that last piece. And you're usually done after that, but or you think you're done after that. What usually happens is this, right? Every endoscopic surgeon knows what this is. I know I'm not the only one visiting Japan in my endoscopic cases. So now you got to, try not to get upset, right? There's something you got to figure out here. Behind all this red stuff, there's now exposed spinal cord. What do? You can't push in a bipolar, feel for something, start, buzzing. You just don't want to do that. You don't get any redos. So there's, a few tips and tricks, and they don't always work. But these are the frustrations of any endoscopic surgery. You got to know how to, manage this. And this is one of the ways that worked. You can turn the scope, right? This is always pushing in front of our scope. But remember, we can turn this wherever we want. So, getting away from that continuous pulsation of blood can help pretty significantly. Then you get a better idea. You start identifying where bone is. You know where medial is again. You put this thing in a safe spot. And typically, without even turning it on, if you're blocking that that blood vessel that's bleeding, without even turning it on, it usually works. It's just blocking it. So you know you're at the right space, then you turn it on, and then sometimes you get lucky. Other ways to do this is some folks add, epinephrine to their irrigation. We've talked about studying this. And there's another, if it's bone bleeding, you can sometimes stick bone wax in there and use a pituitary to sort of push it down into the bone. Sometimes I like to take, if it's bone bleeding, take some tissue that's loose in there, stick it on the bone, and then bipolar over that hole. Sometimes that works as well. But sometimes even waiting works, right? For those of us who are used to doing ETVs, what happens when it bleeds in the ventricle? You just wait, you wash it out, and sooner or later this sort of clears up. So patience is key. Sometimes you don't have it when you're doing some of these longer cases, but I think it's an important thing to sort of train yourself for. And these are the final pictures. You want to make sure that this whole spinal cord is decompressed where you wanted it to. So you confirm that obviously with the X-rays, but also under direct visualization. So what we're seeing here, it looks like, let's go back here. It looks like this is all lateral to the spinal cord, but what we're actually seeing is ventral to the spinal cord. So if we put a ball tip there, that's going to be contralateral on the other side of the spinous process. So we have a really nice angle here. And what you're seeing also, and how I like to tell my residents too, it's that you want to follow that river of disc into and ventral to that spinal cord. And as long as you don't find like a dam on top of that river, then you're good, you're decompressed. If you see something on top of that, that probably needs to go. So that's how you really confirm you're done. And with all those, technical things that we now learned, we can tackle these cases because it's rinse and repeat, right? You got to do the same thing over and over. So 57, she was told the same thing. She was only complaining about pain. This is too dangerous. You may get better, but it's going to be a big surgery. In fact, objectively on examination, she was severely myelopathic, but she wasn't even complaining of that. She just wanted the pain to go away. So you always get a CT, right? And you're going to find it's calcified almost 65% of the time. And what I'm recently always saying is it's not enough just to know whether it's calcified or not. It's not a black and white thing. It's how much is it calcified, where is the calcification, because it's going to have implications on what instrument you're going to be using, right? Does it have a rim? Are you going to be able to use that rim and sort of maneuver the disc? Or are you going to be picking at it like a stale cookie? And this is going to be probably like a stale cookie if we had to guess, right? It's a bunch of scattered calcifications in this disc. So it really changes the type of surgery that you're going to do, and it's important to anticipate that before you do it. Again, that's a spinal needle. It's not going anywhere. Same picture. You're having the drill on that SAP. You drill through the SAP. You take the disc out. You want to feel above and below. That's that medial reach that we're able to see. Some key pictures: IAP, joint space, SAP. Drill off that SAP, then you start getting into the space. So you see the little spinal cord, and you see some of the SAP that's remaining there. Then you already see that disc herniation there. That's that curved bipolar going ventral to the spinal cord after you made some space, and then you got some discs to take out there. That's after the disc is gone, so there's a lot of room in front of that spinal cord, and that's how it looks like. That's exactly what we expected. Just this bunch of crumbly, calcified disc stuff. No surprises, right? And that's the goal. Like, we want to minimize the amount of surprises in surgery. So you can see that that's all ventral to the spinal cord, and that's all decompressed. That's pre-op, that's post-op, that's the approach, we all know how these incisions look. She was discharged same day without narcotics. When you think about thoracics, right? There's no chest tube, there's no approach surgeon, there's no rib resection, there's no ICU stay. During the surgery, we're pushing maps because we're still dealing with the thoracic spinal cord. So I like to keep it over 85 throughout the case, but we monitor them post-operatively. But after that, if they're feeling good, they can go. I apologize for some of these people who've been to these recent conferences. They've seen these cases before. These very recent conferences, we're talking about these. But I think it's a good case to show. This is a young patient, high BMI, really giant disc, thankfully nicely paracentral, right? So you get a little excited when it's pushed over to one side. This is already a retractor for you. It's there, right? So you know the spinal cord's pushed out of your way, and you can sort of deal with that. And severely myelopathic, can send it for the OR. So, but I put the scout picture in there because it helps you understand the technical challenges of any approach, right? So, imagine doing a posterior calcitransversectomy, lateral approach, anterior, whatever. It's going to be a hard, long day, and the colleagues that you recruit to help you for that surgery are not going to like you very much. So this is T910 disc. Always get a CT here. It's not just enough to know whether it's calcified, how much is it calcified and what areas are calcified. This has a rim of calcification, so you can use that rim to help you in your surgery. Most of your work is going to be inside that disc, and you're going to anticipate after you eggshell that off, that's going to be your last thing. You don't want to go to medial, decompress the cord, and then keep dealing with the cord that's coming in your way while you're getting rid of the rest of the disc. The other thing that we're learning here is that it's medial to a pedicle, so we probably have to drill some pedicles off. This was earlier on. I wanted to sort of understand, what we would have to do to get this disc out, so we digitally reconstructed that and subtracted the bone of the anticipated bone resection. So this is IAP, SAP of T10, pedicle of T10, and we want to see the disc in total. It's not a soft disc. You can't reach around corners and pick at it. The best way to deal with this is to see the full thing. So we 3D printed that, and with the bone windows removed of what we're going to anticipate to drill, and that's what we hope to see. We thankfully were able to see that. But this is, you can see, this made the surgery a lot easier. We know what bone we need to drill off. We know what angle of approach we need to take. We know what we're going to see in there when we get down there. So these are the lines I draw, same for everything. You'll see in the lab, it's the midline, it's the level of interest, it's the approach. And here's what it looks like. We've seen a ton of drills in the past couple days, right? We're just drilling through, number one, this pedicle, but also we're going to drill through this disc. So if you see this next picture here, you can see this asterisk, right? That is trying to denote that cortical medial surface of that pedicle, right? So all this other dinosaur egg-looking type of cancellous bone, that drill just sort of eats through. When you reach that cortical edge, you're going to know that on the other side of that is either going to be your disc or your epidural space. In this case, it's going to be the disc, because that disc is right there, medial to that pedicle. So that's that picture right here, right? So you take, again, we see this, we think we know what it is. It's the medial side of that pedicle. We take a picture, and we're happy with that, and it's a confirmatory test. So we can move on, we drill through that, and then we're into the disc, and we got some more disc work to do. And something to say about this is a modified approach, right? This needle isn't in the foramen, right? It's in the lateral side of that SAP and lateral on that pedicle, because we know we're going to want to drill through that pedicle. If we drop down into that in that foramen, we're going to have to really exaggerate that down to drill more of that pedicle. So I felt like that was a more appropriate starting point for us for this case specifically. So this, if anyone's interested in watching more of that video, it's free in JNS, but you can see that first picture there. This is after the pedicle is removed. This is most of this disc removed, but you can see this spinal cord is folding over, and that's because of that last remaining fragment there. So we just turned everything up, took some pituitaries, removed that last piece of fragment, and you can see this nice cylindrical spinal cord now decompressed after that last piece. So that's the pre-op, that's the post-op, that's the approach, and that's the incision. Same thing, same advantages. Really happy with the result. And earlier on we were getting these post-op MRIs because I think for a lot of these proof of concept type surgeries, you want to make sure you're doing the right work and making sure what your imaging looks like matches up to what you thought you saw in the picture. And I think the more and more we do these, the less and less we have to do these confirmatory tests. But obviously the best confirmatory test is how the patient does. So this is what the practice turns into, right? All of a sudden, competing services are just sending these things to you. And it's, it's fun to do. They're fun to receive. And, it's like, we don't do this. We have a guy, and then they just show up. And, again, less than 1% of these of all discs, and all of a sudden in 24 months you're doing 24 cases, and it just it's fun to be a part of. So this is just a super satisfying video. This is what I mean by that last calcified rim, right? There's a lot of drilling right before this, and this is a hollowed out rim of disc that we just teased out with a nerve hook, and obviously very carefully, but you can see that this only works when there's a nice plane there. So, first attempt, if it comes, great. If not, you have more drilling to do. So this is sort of this back and forth thing, but, in all these videos, everyone shows you the good stuff, and that's the good stuff, right? So, data is important. We're collecting a lot of these with the Spine Healthy app, just looking back at these cases. And this we've updated probably like 15 or 20 more patients just through this mobile application, but we're adding a lot to this data, but it all follows the same trend, right? It's matching up to the literature we already know about common levels and symptoms, but what's really, blowing us away, and it again matches up to the previous data, is the type of complications. Sakib talked about the quality of these complications and not just the numbers, and these people are going home, if not the same day, the second day, or post-op day one. Most of these are from myelopathy. 0 patients, chest tubes, rib resection, none of this stuff. I do all of them under general anesthesia, and you look at the blood loss, these are all going to be significant values, right? So, we looked at that, and how do we characterize these patients to be endoscopic candidates, right? There's disc characteristics, patient characteristics, and general considerations. So size of the disc, location of the disc, whether it's paracentral, or if it's extraforaminal, you don't even have to see the spinal cord, right? You're aiming specifically at a very different place. Calcified versus calcified, and then more detail about it, right? Whether it's caudal, cranial, will change your trajectory. The level of pathology, whether you have to deal with the scapula on super skinny patients higher up in the spine, that's a real consideration. The costovertebral joint, if you look at Hofstadter's book, it tells you that costovertebral joint is in your disc space. The higher you go in the spine, it moves further away from the disc, the lower you go. And you miss shallow, if you get no do-overs, whether it's a spinal cord or the aorta. And then you got to be patient. You can't plunge. So, again, Christoph, forgive me. I know you're trying to standardize the nomenclature here, so everyone ignore that ET, DR. But what you want to take away from this is, if you want to do your first thoracic case and you're already doing endoscopic cases, T9 to 12, no calcification, radiculopathy only, less than 50% of the canal, and if it's foraminal or paracentral, and a moderately low BMI, I would say the lower you go, the harder it is, the higher you go, the harder it is. So, less than 40 is a good one, at least for my patient population. So it's good, right? So that would be a nice, I used to say chip shot case, but then I started playing golf, and a chip shot's not easy. So, then...
Cases with this algorithm.
What was that?
I don't want to get all the cases with that algorithm built. I'm sorry.
No.
Floating around Pennsylvania.
Yeah. I hand this out at the town fair. Yeah. So it's a team effort, right? It's a ton of people getting the equipment, getting the right stuff, making sure they're all working, but also talking to the patients, enrolling them in important programs that follow outcomes, and really just helping out follow these patients, because we're really doing a lot of different things that people are not used to, right? So, always like to put one slide for everyone on the team there. So, the perfect patient for endo, we all know after these few days at the very least that there's no perfect patient, that you can't even ask that question anymore. We're just applying it everywhere. I think we're actually here, right? Especially when we look at the thoracic applications, right? I think once everyone starts doing this, you're not going to do it any other way. You can't even like offer another approach. And it's early on, it's all about the conversation you have with the patient, right? Your first case of thoracic is always going to be your first case. That has to happen. It's number one is going to have to happen. So you tell them, we're going to try this thing. It's in a very dangerous area, and if we don't get it, we can always give you the surgery that you'd have gotten anyway, right? So, and they're always going to go for that because they're, well, why wouldn't you? So this is a video of that, that large calcified disc that's been haunting us throughout this whole talk. That's the last rim of calcification that's left. You can see it's all hollowed out over here, and that's central. That's the spinal cord, and that's this feeler just removing that last calcified portion of disc. Remember that was your retractor. You remove that, and then you start seeing all this free spinal cord after. So that's a nice thing to see visually to know that you're done. So main takeaways: plan, level of surgery, get a static instrument there, whether that's a pellet put by IR or your spinal needle, miss shallow. Everything is patient specific. Work from outside in, something I didn't really talk about, but drill out first. You never want to find spinal cord and then start doing more work outside. You want to expose a sensitive thing last. And then, calcified versus not calcified, and then you have to know more information. Trust the fat. You can't plunge. You get no redos. It's the same risks and complications and considerations as any other thing. We just try to minimize them. And then patient discussion is important. So that's all I have for that. And any questions, we're happy to answer. Yeah, Mark.
Yeah, in the open literature, there's this wonderful thing known as the transdural disc, right? Mm-hmm. Like you hear that all the time. That in the open surgery, they're like, "Oh yeah, that disc was transdural." How many transdural discs have you seen in your endoscopic cases?
0 so far. I'm not saying they don't exist. There have been 1 or 2 that I just left floating. So I didn't investigate whether they were complete transdural, but just disconnecting them. Again, the benefit of hollowing that calcified disc out first is that even if you can't peel it off, you just have to detach it, and then it's already decompressed. So I haven't seen any, but I'll let you know when I do. And then I'll also say it was already intradural.
It would be for the experts, endoscopic.
Quick question. How soon are these post-operative MRIs? Because obviously in open or other types of approaches, you don't even want to get one because it looks so bad. What do you have to say about like post-op imaging?
These were same day or next day.
Wow.
Yeah.
So to Mark's question about transdural, I haven't seen transdural, but I have seen spontaneous CSF leak, and I think you've done this. I think
Yep.
John's done one. So I've seen a hole eroded in the duro that was leaking on the pre-op myelogram, not just the post-op one. So, but nothing like all the way through the dura. I just want to sort of emphasize a couple points that you made. So, like the fact that endoscopic surgery redefines failure, right? Like, what's the downside of trying this when your alternative is a costotransverstectomy and a 6-level fusion? And we're looking at, for instance, the cost of this compared to an open approach. And you could fail 50% of the time with this and it's still cost effective. Like, it's immense.
Hey, really nice talk, and these are difficult cases. Now, 2 things to that. I think the REMA for this case really makes a huge difference, and not so much, about the getting into the foramen. That's pretty easy, and also you can, taking the exiting nerve root is not a big deal. But in particular, to get that proximal piece of the rib, the rostral part of the rib, and the REMA allows you to shave that down and gets you much, much better into the foramen. So I'm really excited about, that you do the demonstration. I'm curious how you deal with that. Do you ever go out and sort of resect a little bit of that rib? If you can't get the trajectory into the inferior part, for example, with that calcified disc, you had to go to the mid portion of the inferior vertebral body. So that's where the rib is right in your way, and that's where the reamers are. I always use them for that reason, because it gets you right to where you have to be.
Yeah, I think those are good points. For me, if you plan on drilling early, it's fast. If you change your workflow in the middle of the surgery, then it starts to get a little bit annoying. So if I dock somewhere and I know I'm going to start drilling in that place, I stick the scope in and I start drilling. And then whether it's rib or pedicle or SAP in my way, I'm drilling it. I already planned it, right? So that it doesn't change much as far as, what specific bone it is, as long as I'm heading in the right trajectory I need to go in that I planned. And I think that for me works better. When I use the reamers, I put the scope in, and the reamers are so effective that they're too big to get out of the scope. So it's a lot of in and out stuff for me, at least, that I avoid just by drilling up front.
That's an excellent talk, and you probably should have a commercial in Pennsylvania to add to your patient population. But well, one question that you kind of I have that you kind of brought up is this floating technique, and it's always a question to me is once you core it out, this calcified disc, and you're trying to get that plane between the thecal sac and that rim. I kind of just keep chasing it, but at what point do you just say, okay, I'm going to float this? Do you wait for the signals to start being affected, or what do you wait for?
You look at other things in your view, right? If you're pulling the disc and that cord keeps coming, then you just stop. That's really what it is, right? Because if it's going to peel off, the spinal cord and the dura isn't coming your way also. And then, I guess it's always going to come initially if it's stuck, but if it gives a little bit, and you do it slow, and if it gives, then you keep going. But I have no problem leaving a little piece attached to the dura.
Just out of own bad experience there, I really loved the video. Not only did you drill a void into the vertebral body, which everybody does, but when I watched your video, what you did is you were pushing with a nerve hook, that last fragment away from the spinal cord. It's very easy to grab it with a pituitary, pull into the spinal cord, right? Because you pull backwards into the cord. So especially with the curved grasper that kind of goes in like this, and then you pull, and on the way out, you pull on the spinal cord, and that's very, very easy. That's often the last bite where you do damage. So that was beautiful.
Thanks. And you have to be patient too. For that, I would admit I didn't show that in the video, but you take it out in one piece. It was a big piece, right? It doesn't even fit through the tubular retractor. So I spent another 20 minutes getting it through the skin because it got stuck.
Leave it there.
Yeah, I mean. Exactly.
Just a little memento.
Yeah, Osama.
So one thing, I've had an experience where the disc was up. Yeah. So I talked to Christoph about this after the case where there was not a plane there at all. It was a soft disc or a softer. So I also floated it. And I talked to Christoph. He's like, just leave it and see what happens. And I got an MRI 2 years later, and it was gone. So I think, or not gone, but just a lot smaller. So I think floating, probably not a calcified disc, potentially devascularizes it, and it goes away. So that's something else to keep in mind if you don't have a good plane. So I don't know if anybody else had an experience like that.
Well, I would just say, having done this all the different ways, that I've definitely floated plenty of calcified pieces. When we do it transthoracic, et cetera, you just don't feel like you can peel it off without damaging something. And of course, people can do well with that. So I think just because we're doing it endoscopically and we can see a whole lot better doesn't mean we have to necessarily take every last bit out.
Yeah, and the uniportal, the maneuverability is, if it'd be nice to have a bunch of hands in there and really just hold things and peel off, but you really don't have that fine sort of motion to work and peel. It's probably a little bit more.
I think the technique is perfect, and I don't think people should really end up doing thoracic discs any other way in the future. But the challenge for us right now is dealing with the not being perfect. You can see so much better than you could ever see before the underside of the dura, that you just kind of want to take all this stuff out, even though you don't probably have to. And I think that's probably the harder part.
I noticed, have you ever used, doesn't seem like anyone's using any like side firing or straight firing laser anymore, like just to maybe break that up before you take it out and slice it in half or something, or even just get the last rim. Is anyone using laser anymore?
I don't have any experience with that, but I could see how that'd be helpful.
I think that's a great point. I think that the lasers kind of fell out of fashion, but I think that there is a place for it. Yeah, it is expensive. It's hard to get it in certain centers, but. Well, Sanjay, that was a great talk. Thank you so much.
Thank you.
So we're going to give Sanjay about like a few.